Hello, everyone. Before starting, I wanted to thank you, Dr. Joseph Shukroon, who did the first part of this presentation. And I take it over from here for the second part, which is intitulated The Applications of PRF in Soft Tissue Surgery. As you know, the blood extracts are commonly used in oral surgery, especially in wound healing, socket preservation, on top of grafting materials or in maxillary sinus grafting procedures. But the aim of the communication today was to talk to you about the blood extracts, especially the PRF, the platelet-rich fibrin in soft tissue surgery. Before starting, a little reminder on why we do soft tissue surgery is mainly for two reasons. The first reason are the recessions, and the second reason are pre-prosthetic surgery. The definition of recessions is, according to the American Academy of Periodontology in 1999, is the apical migration of the gingival margin beyond the cement-enamel junction. And it's usually multifactorial, many causes, and the anatomical cause is the main factor. There have been many classifications done by many authors. The one which is well known is the classification of Miller, done in 1985, which classifies the recession based on the degree of involvement of the periodontal tissues. But you should know that there are more recent classifications, especially the two last ones, the Pini-Prado and his team, and Cario and his team in 2010 and 2011, that have classified recessions differently, taking into account practically all kinds of recessions that we can encounter in our everyday practice. The indications of the soft tissue surgery, you have many indications of soft tissue surgery, but the main indications, the main reasons why we do soft tissue surgery are, first of all, aesthetics. Patients come for aesthetic problems, hypersensibility of teeth, where you have recessions, because as you say, the radical surface is not very well protected by a layer of enamel. So you can have sensibility that can be sometimes awful for the patient. Problems of decay on the radical surface, as I told you, it's not protected by enamel surface, so it can decay. And the evolution of the recessions. A lot of patients come and consult because they see the recessions and they think that they're going to lose their teeth. So that is one of the main reasons why the patients consult for the recession problems. The other fact, I talked to you about the recessions, then we have the pre-prosthetic surgery. Before doing any kind of white aesthetics, taking care of the white restoration, it's a good thing to look a little onto the pink aesthetics, into the keratinized tissue around the abutments that are going to receive the restoration. Because as you know, we can have recessions if the soft tissue is not of good quantity or good quality, or both of them. Then we can have recessions in time around your restoration, which can be problematic for the patients and therefore for us. There have been different surgical techniques described in the literature and used every day by all kinds of practitioners all around the world. The aim of this lecture is not to talk about the different techniques available. You can use basically any technique you are comfortable with. The most common technique used around the world and that we use in our philosophy is the connective tissue grafts associated mainly with the repositioned flaps, mainly coronary positioned flap. And then the donor sites. The donor site in the buccal cavity, well, we don't have that many donor sites. You only have 3 donor sites. The palatal site, which is the main donor site. You have the tuberosity, sometimes we can be a small donor site, or the edentulous crest when you have one. One of the big problems with the donor site is the post-operative complaints of the patients, because the donor site takes time to heal. You have a normal clinical healing, which takes around 4 weeks. You have 10 to 15 days for the donor site to be epithelialized. from the sides, and then still 10 to 15 days for it to close totally. So this can be a big source of discomfort for the patients after the surgery. And the most common technique, as I told you, that we use are the free connective tissue grafts associated with coronary position flap. So to make things simple, I've done a plan in 3 points to continue this lecture. We talk about additive surgery, sister-active surgery, and why not additive and sister-active surgery in one go, in one shot. Additive surgery. Additive surgery, as I said, most of the additive surgery are the connective free tissue grafts associated with different kind of flaps. These surgeries give good results. The only problem is that we have limited amount of tissue graft that we can harvest from a palatal side of the patient, and so it is not always evident to do large cases or multiple recessions in a patient in one go, in just one surgery. As you can see in this surgery, we can cover one root very easily by harvesting a little amount of connective tissue from the palatal side. But when we have bigger sites, here we have a preprosthetic surgery to reinforce the quality and the quantity of the soft tissue before doing the restorations. But as you can see, we need a huge amount of connective tissue, and it's not always easy to go and harvest a huge amount of connective tissue. Sometimes it's not possible, and when it's possible, it takes us a big surgery to do it, and this can give complications, and this can give post-operative complications and post-operative problems to the patients. Well, in this case, as you can see, we have treated the whole interior zone with with 2 huge connective tissue grafts. The results are predictable and good, but as you can see, we have done a double harvesting on the palatal side, which can be a huge source of discomfort for the patient. And we can have, as I said, other problems. We can have hemorrhage problems, vascular lesion, you can have necrosis of the harvesting site, and all these are discomforts for the patient. So the inconvenience of the traditional technique, as I said, for doing big surgeries, for doing large surgeries, for doing multiple recessions, is that we need an important quantity of connective tissue. I'm not even talking about the quality, it's quantity. And so the more important surgery, with all the problem is we do a more important surgery, then we have all the per and post-operative complications that go with it. The solution that we are using since a few years now, we have started to work with the PRF membrane since 2000, especially in soft tissue surgeries since 2004, 2005. We decided to associate the PRF membranes, the platelet-rich fibrin membranes, with the connective tissue grafts, with the large connective tissue grafts on large sites, in order to have good results with the least inconvenience and post-operative complications possible. One case of recession, as you can see, multiple recessions that we can do maybe in a normal technique. We can do this case in 2 or 3 surgeries in order to cover all the recessions. Or we can do it in one shot. We do a semi-thickness flap, a little connective tissue harvesting, which is cut into little pieces and dispatched on the whole site, covered by huge amounts of PRF membranes, and then a tension-free closure of the flap. We don't have to track the flap that much to have a very good closure, because we can have the PRF membranes, the fibrin membranes, exposed to the oral cavity, to the buccal cavity, and it will protect the wound. So one of the advantages of this technique is that we can have tension-free flaps around our connective tissue graft. These are the kind of results that we get after 10 days. And these are the kind of results that we get only after 4 weeks, which is not much. Another case, which is older now, to some some follow-up. Multiple recessions, little flat, little connective tissue graft, large amounts of PRF membranes. These are fibrin membranes. They stick to your side. You don't have to suture them. They will just stick on the side, and they will keep your connective tissue graft practically in place. And then we do a tension-free flap to close the whole thing up. And these are the kind of results that you see on the right-hand side just after a few days in the same week. And these are the results that we get after a few years. This is a result after 6 years. As we can see, the results are stable in time and predictable, of course. The other thing with the PRF membranes is negotiating the harvesting site. As you can see, what we do is after harvesting a little connective tissue graft, we will fill the site with a few PRF membranes, 2, 3, or 4 membranes, depending on the depth of the site. And this is the closure at time 0, the day of the surgery. This is the kind of result that we get after 48 hours. As you can see, the site is almost closed. And this will prevent us having infection, and will prevent having patient having discomfort for the patient. And this is the kind of result that we get after 1 week. Without the PRF membranes, this kind of result we will get after 2 or even 3 weeks. So we gain time. Preprosthetic surgery, additive preprosthetic surgery. Patient referred for the white aesthetics, as you can see, but the problem is not only the white restoration. As you can look, you can see the soft tissue is deficient in quality and in quantity. So if we just change the white restorations, then we will have the same problems of recessions in time, 2 years, 3 years, 4 years afterwards. So the first thing to do in these cases before touching the white aesthetics is taking care of the pink aesthetics. So what we do is we add a little amount of connective tissue covered with the huge amounts of PRF membranes, fibrin which sticks to the site, and we do a tension-free flap. We don't have to close it completely. It's not necessary. The fibrin will protect the site. These are the results that we get very quickly after the surgery. And then we have sufficient tissue to do some subtractive surgery. And after some time, after a few weeks, I think here is like around 10 to 12 weeks, this is the kind of results that we get. We have reestablished a good quality and quantity of keratinized tissue around the natural abutments in order to receive the restorations to come. And as you can see, once the restorations are done, we can be sure that these recessions will not, we would not have any more recessions in time, which is the most important thing. Predictable results. Another case, patient referred for a problem of white aesthetics, but if you look, you can see recessions on both sides and very, very thin connective tissue around the teeth. So the first thing to do is to take care of the soft tissues. We take a little connective tissue graft, we cut it into pieces, we dispatch it on the whole site. It goes from premolar to premolar. We cover the whole thing up with PRF membranes, and we suture with tension-free sutures. The flap is completely tension-free. And these are the kind of results that we get after a few days. And then you do a little subtractive surgery to line everything up. And then doing the white aesthetics is just a formality. So we go from this situation on your left-hand side to this situation on your right-hand side. As you can see, we've changed the white aesthetic. That is one thing, but we have reinforced the pink aesthetics. So we'll have a good result in time. This is 2 years after the restoration. As you can see, we have very good quantity and quality of keratinized tissue around the restoration. We can also take care of edentulous crests, which are flat. When teeth are lost after some time, you will have thin crests. And once we have taken care of the teeth prosthetically, then we can also take care of the crest. We take a little connective tissue graft. It's always the same thing, the same procedure. We can wrap them up in PRF membranes, or we can just put them in the pocket and then put the PRF membranes over them. And then we go immediately from this situation into this situation in half an hour. And when you have enough tissue, then you can do a little cystoactive surgery and recreate some kind of papilla. And this kind of papilla will allow you to do more aesthetic restorations to come. Very easy, just one single surgery. I just do one point on the cystoactive surgery. As I told you, additive surgery, cystoactive surgery. The cystoactive surgery has nothing to do with the PRF, as you can guess. Either it is just soft tissue cystoactive surgery, as you can see, very simple, just a retouch of the gingiva, and you can have better results, better aesthetic results. As you can see, we have lined up here before doing the prosthetics on the right-hand side. Or you can do hard tissue retouch to recreate the biological space, the biological width, before going through and doing your restorations. And we systematically use piezosurgery to do this. We don't use any more rotative instruments. We have much better results with much less post-operative complications. As you can see here, the main problem is not decay or the ancient restorations. The problem is the non-respect of the biological width. So once we reestablish the biological width or space, we will we get rid of the inflammation. So we go from this situation to this. Then the problem here was not really the white aesthetics, it was mainly the pink aesthetics with the non-respect of the biological width. So normally we used to do cystoactive surgery and then do additive surgery in the second time. Since we've been using PRF membranes, we do both surgeries at the same time. Patient referred for changing the restorations. As you can see, the soft tissue here, the keratinized tissue, is deficient in quality and quantity. So before going through with the white aesthetics, we are going to take care of the pink aesthetics. But when we take the ancient restorations off, we see decay problems. And when we take care of the decay problems, we are faced with, if we're going to do restorations, we are faced with the problem of biological width to come, because we will be too close to the crestal level. So this case needs both cystoactive surgery in the first place and additive surgery in the second place. So what we do is to combine the two surgeries. At the first place, we do the cystoactive surgery using piezosurgery to do our crown lengthening, to reestablish the biological width, as you can see. And then at the same time, same operative time, we harvest a little connective tissue graft that we cut, as I said to you before, into little pieces. We don't need a lot of tissue. We will dispatch it on the whole site, and we cover the whole thing up with PRF membranes. Sometimes we don't even need to suture the connective tissue. And then we close our flap as well as possible without any tension. Because as I said before, we don't need to close it completely, knowing that the fibrin will protect the wound. And these are the kind of results that we get within few weeks. And that allows us to go from this situation on the bottom left to this situation on bottom right. We have established the white aesthetics, we've established the biological width, and we have established the quality and the quantity of the soft tissue and the keratinized tissue to have a better aesthetic results in time. So, for the conclusion, I put it in two words: in advantages and inconvenience. The advantage of using the PRF technique is that it is possible to do in a dental office. There is no manipulation of the blood, and the machine is extremely ergonomic and it's easy to do. So there's something that we can do in an everyday practice in the dental office. It's costless. It does not cost very much. Doing membranes, 8 membranes at once, does not cost very much. It will give us a very fast wound closure. That will allow us to have less post-operative complications. And so on, we can do bigger and wider surgeries. And we can combine surgeries. It's easy to do a tension-free flap closure because, as I told you before, the fibrin will protect your wound, so you don't have to manipulate your flap that much. You don't have to tract your flap or pull on it as much as you normally do. It's possible to do multiple recessions in one surgery. We do multiple recessions in one surgery because we are using less and less connective tissues during our surgeries. It's possible to do soustractive and additive surgery at once in one go. As I said, we can accumulate surgeries. We can do 2 surgeries in one. And we have better quality and better quantity of keratinized soft tissue around our natural abutments or around the restoration. And the inconvenience, to be honest with you, there are none. There are no inconvenience. It is autologous blood extracts that you use instantly once taken from the patient on the patient. So I have finished. Thank you very much for your time and for your attention. And I hope that I will have the chance of being with you for maybe some new adventures. Thank you very much. Thank you.